A lot of doctors that started day hospitals started them because they were frustrated with both the public and the private system, and they felt there was a better way of providing a service to their patients. So a lot of the smaller independent day hospitals, and they actually make up the majority of the sector, 65% of the sector is small independent day hospitals. That way, it was a one-stop shop for their patients. They could see them in the rooms, they could have their surgery, and then their post-operative visit was back in the rooms right next to the day hospital. So it made a lot of sense.
Today we've got Jane Griffiths from Day Hospitals Australia. Welcome, Jane.
Thank you, Adam.
I just wanted to start off today's podcast with a really simple question, something that when I talk to people about our work with day hospitals often comes up, and that's quite simply, what is a day hospital and what do they do?
Okay, well, day hospitals do vary in size and scope and risk. There are 357 day hospitals spread across Australia, both in rural areas and the metropolitan areas, but the official definition of a standalone day hospital internationally is admission and discharge in less than 24 hours. However, the bulk of day hospitals in Australia at the moment would have patients discharged between 2 and 6 hours. However, we're slowly increasing the more advanced procedures, such as joint replacements, that are now being done on a same-day basis, and those patients obviously would be in overnight, but in for less than 24 hours.
And
so
Jane,
that's basically the definition.
And Jane, in the scheme of healthcare and our healthcare system with hospitals and doctors and our whole framework, where do day hospitals fit in that framework?
Day hospitals are the most cost-effective part of particularly the private sector. However, they're now various state governments are looking at developing public day hospitals, and there are 2 in Queensland at the moment, one of whom's a member of ours already. So our role in the healthcare system as a whole, as the most cost-effective part of the healthcare system, is to ensure the sustainability of our healthcare system.
How important is that sustainability? Because I'm aware of pressures on our healthcare system. So just while we're talking about that, I think that's such an important point. So,
yes. You're probably aware that Minister Butler in recent months has asked the department to conduct a financial health check of the private hospital sector. So that includes all private hospitals, including day hospitals. And the situation is quite dire, and there are several reasons for that. One is that since the pandemic, for whatever reason, particularly the overnight hospitals have not resumed their previous capacity. We're not sure if that's because patients are suffering from the effects of the current economic climate and putting off surgery, even if they're insured. Medical gaps could be another reason that they may not be undertaking their surgery, but also just the pressures on any business obviously is impacting all types of hospitals. And the other area that's been significant is the increase in the cost of surgical and medical consumables, between 10 and 20%. Now, some of that increase has been due to the prosthesis list reforms that occurred a couple of years ago, which meant the sponsors of those prostheses had their prices cut, basically. So they're trying to gain back what they've lost by increasing their cost of their other supplies that don't fit into the prosthesis category. The other threat, of course, is the various jurisdictions have had significant pay rises for nurses, but now looming is federally in the Fair Work Commission, the ANMF have applied for a 35% increase in the award rate for nurses. Now that will cripple the private sector. So there are a lot of pressures facing the private sector, but the important point here is that if the private sector collapses, and particularly the most cost-effective part, then the public sector that's already under extreme pressure will just not cope. So this is why the Minister has introduced the health check. We're hoping to hear what he's thinking of doing about that in the very near future.
Jane, you just mentioned there that day hospitals are so cost effective, and you mentioned recently that day hospitals could save the government $500 million, which must have raised a few eyebrows. Can you please drill down into that and explain that situation?
Yes. With the private health funding, which at the moment funds the majority of day hospitals and private overnight hospitals, the funding model was developed long before day hospitals existed, so around 5 to 6 decades ago. And there wasn't a lot of work done on a same-day basis at that point. However, the first day hospital opened in Melbourne, in Dandenong actually, in 1989, and then the sector started to grow in the 90s, and then has significantly grown over the last 20 years. However, the original funding that was given to day hospitals in the beginning was extremely low, and that's what's been built on. That's the base that the insurers have built on. But what's happened in the overnight sector is they too have dramatically increased the number of same-day procedures they're doing, but they're doing it at a very high cost, which is where that $500 million saving comes in. So that's actually affected their bottom line. So just for argument's sake, where they might have received $3,000 for a patient, now they're only receiving $1,000 because it's being done on a same-day basis. And they used to use those procedures to cross-subsidise their complex procedures, but it's just not covering them anymore. So obviously the funding model for both parts of the sector is broken. And they really need to, the insurers are a bit over a barrel, as well, as I'm sure you've seen in the press, where big corporate overnight hospitals such as Ramsay's, Healthscope, and to a lesser degree the Catholics, where if they don't get their way, they refuse to contract until they do. So the insurers are basically the price takers in that scenario, whereas the day hospitals in their negotiation have to accept what's left in the pool of money because there's only so much money. So that's why I think this health check is so important. And recently we released a document called The Fork in the Road, which literally says, unless we do something, we are in danger of losing possibly the day hospital sector altogether and some of the private sector. We've seen 49 day hospitals close since 2019, but on the other hand, we've seen an increase in people still building day hospitals because they know this is the future. We've also seen around 20 overnight hospitals close. But what's happened in that whole decades that I explained, the overnight hospitals have overcapitalised on theatres and beds to a certain degree. So they're accommodating in their hospital operating rooms all those same-day patients, a lot of whom could be accommodated at a much cheaper cost and probably a better outcome in the day hospital sector. And as you would know from your own patient experience results, I think the report I got this year, 96% satisfaction and patient experience is, I think, something that the overnights would not be able to demonstrate. I have no proof of that, but certainly what we find is patients really like the day hospital experience. They just want to go into hospital, have whatever has to be done and get out as soon as possible.
Yeah, for sure. And do you think with demographics of an aging population, I mean, that crossroads feels like it's even more
it is. Imminent. And interestingly enough, elderly patients do very well in day hospitals. because when they go into large institutions, particularly if they're having anaesthesia, they tend to become very disorientated. They often tend to have falls because the area that they're in is not familiar to them. Whereas if they're in a day hospital, they're in and out fairly quickly, and providing they have an appropriate escort person, which every patient needs post-treatment, whether it's surgery or medical treatment, then they're able to do things for themselves when they go home. They don't tend to fall because they're in familiar surroundings, and they can do things like make a cup of tea and small little tasks, so they tend to recover very quickly.
And if they're in the home care, if they're in the home support and home care system, it can maybe complement each other quite nicely there.
Yes, that's right. Well, as we do more advanced procedures such as joint replacements, there needs to be collaboration between the day hospital and the rehabilitation service or the GP service or the nursing service, whatever the patient requires. So you see a lot more of that in the future.
Where do you think the friction point lies, Jane? Because this might be a relatively new sector, but it's been around long enough for people to have accepted it. Like, I'm sure regular people haven't heard about the concept of a day hospital. Has it just been a slow uptake by the government and policymakers?
I would say it's been a slow uptake by the doctors. I mean, the doctors are very comfortable doing all their cases in the one place. A lot of doctors that started day hospitals, though, started them because they were frustrated with both the public and the private system, and they felt there was a better way of providing a service to their patients. So a lot of the smaller independent day hospitals, and they actually make up the majority of the sector, 65% of the sector is small independent day hospitals, and only 35% belong to the groups of day hospitals. So that way it was a one-stop shop for their patients. They could see them in the rooms, they could have their surgery, and then their post-operative visit was back in the rooms right next to the day hospital. So it made a lot of sense. So they were sold. And of course, ophthalmology was the first specialty to do that. And we now do 90% of all ophthalmology. Gastroenterology is the next biggest specialty, but as the fork in the road document demonstrates, we're only doing 70%, and that's a concern when it's so much more expensive in the overnight sector. But with the change that's needed in the funding model, we have to be very careful that we don't cause the overnights to collapse, and at the same time that the day hospitals are profitable. But getting back to the doctors, a lot of younger doctors now that have worked overseas have worked in ambulatory surgery centres, NHS day hospitals in Scandinavia where they're very well established. So they're frustrated when they come back and they're having to do same-day procedures in overnight hospitals. Just recently, we had a spinal surgeon from Melbourne at our conference on our medical panel, which was the purpose of the panel was to demonstrate the benefits to not only patients but also doctors working in this environment. And he's found that very challenging since he's come back. He was in New York for 6 years doing standalone AC, which is the ambulatory surgery centre, spinal surgery. So there are a lot of surgery that actually benefits from the short stay, orthopedics in particular, because one of the biggest risks for orthopedics is infection, particularly for joint replacements. So, if you said to a patient who didn't understand the concept of a day hospital, you're going to have your joint replacement and you're going to get up and walk 3 hours after you've come out of theatre, they'd probably freak out. However, for those procedures, there's a 2-week lead-up time before the patient comes into the hospital. So the patient is contacted by the hospital, contacted by the rehabilitation people, so that they're having all that education before they actually come in. So when they come in, they know what the expectations are. They don't freak out when they have to get up 3 hours after their surgery, and they're pleased to go home. And this is partly because a lot of people having joints these days are still very fit right up to their 80s. And they're used to walking or riding bikes or doing some sort of physical activity, and they want to get back to it as soon as possible. And often the only problem that they have is their joint, and otherwise they're fit and healthy. So patient selection is a critical element of same-day surgery. So that can never be dismissed, because that is really, really important. But it's about educating our medical fraternity of the benefits, not only to them and the patient, but to the system as a whole. Most doctors would not understand. In fact, they'd probably be quite shocked if they realised what the hospitals were being paid and what the differential is. So we've actually taken on 6 medical societies as members. So we're slowly educating doctors through that process, but there's a lot of work to do. But certainly the young fellows that are coming back to Australia, they're going to be much more likely to embrace this model of care than the doctors that are set in their ways and still doing same-day cases in between large cases, because they just don't understand the impact on the sector. But if we're not very careful, if we don't do something, and we need some probably legislative levers to do that, then we could see devastation in the private sector. The insurers, they know this is where the work should be done, but their hands are tied while we've got this current model in place, and while they don't have any power with the large corporates.
Just speaking about people going overseas and coming back with experience, just going back to the late 90s when you did a couple of months going around America.
Yes.
How did that inspire your approach when you returned home, and what influence did that have on the people that you worked with?
I was really very fortunate to have a very lateral thinking CEO at the time. It was a large Catholic hospital. And what we were proposing to do was to build a medical clinic and put the theatres and a same-day admission and discharge area on the top floor of the medical clinic, so that patients having same-day surgery wouldn't even come into the hospital. It'd be almost like a standalone facility. So she managed to convince the corporate body that I should go and look at ambulatory surgery in the US. And that was the turning point for me. I realised how much better it was. The outcomes were so much better for the patients. It was cost effective. I mean, I wouldn't for one moment wish the American insurance system on Australia, but certainly their work in ambulatory surgery has been significant. And just to give you a sort of recent example, was during the pandemic, as you know, America suffered badly with COVID, and their hospitals were full of COVID. They didn't close down their ambulatory surgery centres, and in fact, the federal government realised that there could be a lot more done there. And you probably know their Medicare system's a little bit different. So Medicare covers people over 65. And prior to the pandemic, even though the ACs were doing lots of joint replacements, they weren't funded by the government for Medicare patients. But the federal government, I think it was the first year of the pandemic, thought, well, why aren't we funding it in ambulatory surgery centres? So then, again, that was another lever to move those patients into the ACs for their joints, providing they were suitable. So around 30 to 40% of all patients requiring joints are suitable for same-day joints. But certainly that tour, it was a privilege to be able to do it, and it certainly expanded my knowledge significantly. And sort of, it was interesting because unfortunately the CEO and my dream never happened. She unfortunately left before the completion of the building. I was there for about a year, but it was never used properly. It was very frustrating.
Mm.
And as I said, I literally walked over the road to a brand new
Right.
day hospital and opened and licensed and accredited it. And of course, because I knew all the doctors, I was able to attract doctors quite easily into the day hospital sector. So it certainly is the way of the future, and Australia, unfortunately, has lagged really behind with this. It's only been in the last probably 2 or 3 years where we've seen some attempt to bring larger cases into the sector. But of course, the funding model hasn't helped matters. And if people want to develop a day hospital, usually they can't have any guarantee from the insurer that they're going to receive a contract once they open, and that's the frustrating part. So unless this current model is disrupted, I can't see a way forward. So certainly the minister is acutely aware. He has the fork in the road document, and I think that's been a great asset for him to understand what's going on. And you can see by the differences in indexation, apart from the difference in percentage, if you just look at gastro, for the last 10 years, the day hospital sector received 8% in indexation. That's less than 1% a year, whereas the overnight sector received 21%. So for exactly the same procedure. So, you can see the imbalance. That's extreme, and it applies in most specialties. So really the only successful specialty has been ophthalmology. But still there's still 10% that needs to come out of the overnights. And the only reason for someone to go into an overnight for an ophthalmic procedure is if they have huge comorbidities and it's just not safe to do them in a day hospital. But then they should be treated as an overnight patient, not as a day patient. So I was very privileged to do that trip, and in fact now represent Australia on the International Association of Ambulatory Surgery, along with my colleague Dr. John Napoli, who's a gastroenterologist who developed his own day hospital in New South Wales and has been our chapter chair in New South Wales since 2007. So he's very passionate about the sector and the importance of the sector as well. But, the doctors are part of the issue. Another part of the issue is if you regulate where procedures should be done, which is actually in place already. At the moment, there are 3 types of procedure. An A-type procedure requires hospitalisation for at least 1 night, probably more. A B-type procedure can be done on a same-day basis, but it doesn't say where. You can do it in either. And a C-type procedure is usually done out of hospital, but if it's done in hospital, the doctor has to certify why it's being done in hospital to receive funding. So one of the suggestions in the fork in the road is that we have a D-type procedure which must be done in the standalone sector. So they're the sort of levers that the United States had to use when they started moving procedures, and they did start with ophthalmology and gastroenterology as the 2 obvious, very suitable specialties for their area.
What type of outcomes and changes did they see from that, Jane?
Patient outcomes are better. Obviously, patient selection is critical, but because patient selection is critical and patient assessment, not only by the specialist, but also by the clinical staff at the day hospital before the patient comes in, means that there's and you would know that from your statistics, there's hardly ever patients cancelled on admission because they're assessed so well. And that's why the outcomes are good.
Yep.
Plus, there's less risk, as I said, of infection. and other complications, primarily because they're in there for such a short time, because you can control the environment very well, including the staff, policies and procedures in a small unit, which you can't do in a large hospital as easily.
It just seems like such an overlooked mechanism for the healthcare industry, and it can plug so many gaps, and because it's so agile. And actually, the more I looked into your media appearances, one of the things that came up was hospital ramping. It could alleviate that, which seemed to really be exacerbated after the virus and the outbreak. So how would you go about that?
Well, there's a couple of reasons for ambulance ramping. One is elderly patients who decline while they're particularly in the public sector, we're talking, who decline and need to go into care, and there's nowhere to put them. So that's a problem. However, the government, as you know, is looking at aged care packages in the home. That could be a solution where carers come into the home. But of course, if that's happening, but also the number of same-day procedures that are being done in the overnights is taking staff, admission staff, theatre staff are all involved in that. So that's reducing the capacity for the hospital to take patients. The other problem is that in the private sector, those hospitals that have EDs, the ED treatment is not covered by the private health insurer. Only the doctor's fee, not the ED treatment. And yet the hospital has to provide nursing staff, equipment, everything else. So that's another flaw in the system. So the other way that ambulance ramping in the public sector could be addressed is by outsourcing a lot more care to both the day hospital sector and the private hospital sector. Day hospitals are not being used as they could be. And in fact, I met with Peter Dutton about a week ago, and that was his prime concern, was the amount of the length of waiting lists and waiting time for patients in the public sector, and the fact that our sector is not being used as much as it could be. And it's so efficient, you can get through a lot more work. But all the outsourcing has tended to go primarily to the large overnights. There is some going to day hospitals, but not as much as could be.
Another one that came up that you could really cut down on is elective surgery, which a lot of people think it means is synonymous with unnecessary surgery, but what?
It's a very poor term. I mean, the elective surgery just means that it's not emergency surgery, but it still needs to be done. So it's a term that really can confuse people. But when you're looking at the public sector, for example, when they produce the figures on waiting lists, what they're not telling you is how long patients are waiting before they even get on that list, waiting to actually see a specialist. So you can basically double the waiting list because there's a huge wait for patients to even see a specialist. And that's starting to happen in the private sector. I mean, my own husband had to wait 3 months to see a urologist, and he's on top cover. So, and that's, again, I think a result of the pandemic. A lot of doctors have said, I'm not going to work 5 days a week anymore. It's just too hard. I'll work 3 or 4 days a week. So that's had an impact straight away on their waiting lists, which before was unheard of. If you were referred to a specialist, you'd usually be in a couple of weeks. There's also a shortage, particularly ENT, and paediatric ENT is a real concern of mine. I've been interviewed about it several times. Children needing grommets, which is a very simple procedure. I had a service at my first day hospital, a concession service for public patients, and those children will be in for 60 minutes and would be life-changing for them. Because if they don't get it when they need it, then their speech suffers, their learning suffers, and there are children on the public waiting list that have been sitting there for years. So that's a real concern as well. And our sector could be addressing that. But one of the problems is there's not enough ENT surgeons to actually do the work. So that's another issue. And we're not quite sure why that is, but yeah, that's one specialty that in particular that's really suffering. Maybe interestingly as well, there are new specialties emerging in the day hospital sector. One is pain management. So that's becoming quite common, and there are quite a few new day hospitals under development in pain management. We'd like to see more mental health. There's only a couple that are purely day hospitals. A lot of mental health conditions actually get worse if you hospitalise them over a long period of time, particularly conditions like borderline personality disorder. They're much better if they're going home to their familiar surroundings after treatment in a day facility. Sleep studies, much better environment to be doing that sort of activity rather than in a busy overnight hospital. And of course, there are some medical treatments that work really well in day hospitals, oncology and radiotherapy, and the ICON group are a large group of hospitals that are members of ours, and also dialysis. So the dialysis treatment is usually done in half the time, and means that patients can get back to their work or their usual activities much quicker. So it's not only surgery, so, medical treatment as well is emerging in the sector, but we need to see a lot more of it.
And Jane, we talked about educating doctors and other people in the system. How important do you think it is that the general community are educated and that they can have the discussion with their doctor or surgeon and request to be in a place that they want the service?
Yeah, very, very important. As you know, most patients just take whatever the GP tells them as far as where the specialist is going. It's hard to reach all the GPs because they're the linchpin, really. They need to be looking at, is this patient fit and healthy? Are they suitable to have same-day surgery? In which case, should I refer this patient to someone that works in a day hospital? So we do work very well with the AMA, and the new president of the AMA is a GP, and I'm meeting with her in Brisbane in a week or so. So this will be something that I'll be talking to her about, because yes, they can play a really important role. As far as patients are concerned, there's a lot of information on our website for patients about what to ask your GP, but it's a matter of them linking to that website. There are consumer peak bodies. There's a Consumer Health Forum, COTA, and then other specific groups such as the Macular Disease Foundation, etc. We're in touch with all of them, and we would hope that they would direct queries to our website.
Because it's kind of hard, isn't it, Jane? Because people are not interested in these things until you need them, right?
They need them. That's exactly right. So this is why my media has been so important, because that has expanded knowledge, and we've managed to, in the last 12 months, I think I had 13 TV or radio interviews. And, we just need to get that message out there. I think our website has a lot of information on just generally. So if people hear the term day surgery, they're likely to find the website. It pops up quite easily. But there's a lot more to be done, and particularly with the doctors' societies. So, that's a challenge. We're very lucky with our chair of our board is an ex-president of the Royal College of Surgeons. He's a general surgeon. And so he's opened a lot of doors in the medical arena that, where we've been able to talk about the importance of this sector.
Jane, just speaking big picture, it always seems to be a bottleneck issue where there's state and federal government vying for control of different aspects. What can sort of be changed, and is a centralised system a better alternative?
I personally think it is, but when I say that to people, they don't know. So basically what you've got the federal government responsible for the private sector through the PHI Act, and they're responsible for providing a Commonwealth provider number to hospitals around the country that have initially been licensed and accredited through the jurisdictional body. So you've got two people involved there, two different groups involved there. And then, of course, you've got Medicare funding for the public sector, part of which is coming from the Commonwealth government. But the other thing people forget is that the private health insurers are also being funded by the Commonwealth government through the rebate scheme. So, they without that funding, people wouldn't be able to afford it for a start, and they wouldn't probably be able to, as many of them, to exist. But we do work very closely with all health insurers. In fact, I'm speaking at the Australian Health Services Alliance, which is 24 health funds, soon in November. We also speak at doctors' conferences. I'm speaking at the Australian Society of Plastic Surgeons conference next Saturday week. So the more that we do in that area also assists in spreading the word. But as I said, all these young doctors and most of them work overseas, if they're doing a specialty, they've already seen it. They know the situation. So I think it will change with the next generation of doctors. Unfortunately, because Australia lagged behind initially with moving forward with the sector, I think that's been part of the cause. And of course, because the public sector didn't have any either, and that's where doctors are trained. They don't tend to be trained as much, although they are in some hospitals in the private sector. However, I think we would be keen to have trainee doctors in hospitals. The challenge is most of the patients are private, so it depends what role they're going to play. But certainly as more procedures move, and if all ophthalmology moves, that'll be essential for them to learn their craft. So, there's lots of challenges there.
Do you see a space in the future where the day hospital offering might be like a premium solution, or because I mean, everything we look at, the satisfaction of the patient throughout the whole journey is always better. I mean, it's through this conversation, you kind of sit here going, this is just a no-brainer, but I wonder whether that might be some type of model for the future when people understand that their outcomes and their whole journey through that system will be better for them.
Well, something else that we have thought about and we haven't moved forward on as yet is a day hospital private health insurance product that we feel should be cheaper, and more people could then access day hospitals. It means if they needed treatment for a more complex or concerning illness, they would have to go into a public hospital. But it might take some pressure off the public hospital. We did put this forward when I was on Minister Hunt's ministerial committee a few years ago, but we had a lot of opposition, as you can imagine, from the overnight hospitals, but also from the funds themselves. And also the actuaries said it would be too expensive, which doesn't make sense to me. It should be cheaper. So that's something that we'll possibly look at with the insurers in the future, particularly if we get some levers through this latest financial health check that will start moving more work into the sector, then that would, I think, be a good incentive to maybe renegotiate that idea with some of the insurers.
We always talk about the opportunity when things are not looking great and being innovative. So I wonder if a little bit of a push and a little bit of a pull might get us to have something, a new excellent system.
Yes. I think Australia still does have probably one of the best health systems in the world, but I think it's under extreme pressure at the moment in both sectors, public and private. So we're all very hopeful that we will see some initiatives, and they'll have to come from the government. It's the only way it'll happen, to improve matters.
How do you see technology playing a part, Jane? Like, you would have seen so many changes over your career. And now, and with AI coming in and all kinds, it seems to be exponential. There must be such a positive impact on the horizon.
One of the reasons that more advanced procedures can be done in day hospitals is because of technology, but it's also because of improved techniques of anaesthesia and improved surgical techniques. For joints, for example, instead of an anterior approach, it's a posterior approach. So you're not disturbing as much muscle and tissue when you do that joint replacement. So a lot of surgical techniques have allowed this, and certainly technology. We interestingly had 2 presentations at our conference on AI, and one was from a Danish gastroenterologist who's actually done a PhD on AI in medicine, and she uses the AI tools as part of her diagnostic portfolio, if you like. So it will play a part, but there are also dangers associated with it at the moment as well. And that's something, actually, the Commonwealth have started some webinars on that very topic, and how do we control that and make sure that there aren't errors as a result.
Some of the technology must be driven by day hospitals as well, like the need to have things done quickly. So there'd be a lot of innovation in the space that you wouldn't maybe find in others.
I think, because day hospitals are, as we say, specialised centres of excellence, particularly in ophthalmology, they've got all that high-tech equipment, otherwise they wouldn't be able to function. So they tend to get the equipment that they need to deliver that specialty service. And the same with the pain that's starting now. They need a lot of radiology equipment, etc., to do that. So it is a very innovative sector on one hand, but on the other, I think some of the current hospitals need to try and think outside the box and think, can I introduce another service, or what are the opportunities for me to develop further? In the rural areas, day hospitals play a really important part in the community. There's one in New South Wales that went into liquidation a couple of years ago, and there's a real estate company in that town that's really keen to revitalise the hospital because it was so important to the community. And if they don't, patients need to travel for at least 3 hours to the nearest hospital.
Wow.
So they've now got the mayor involved, and so we've done some work with them, and they've got some interest from surgeons from other cities who are prepared to come and do some work, 1 or 2 days a week. So that's how a lot of them need to start thinking about, how do I serve the community better? And one of the big advantages of day hospitals is that they are very close often to where people live.
Makes a lot of sense.
Yeah.
And it seems to have been one of Australia's strong points is thinking outside the box and doing what we can with what we have. So I don't see why it'd be any exception in the hospital and surgery area.
No. Well, in the beginning, we were leaders, but unfortunately fell behind. Not quite sure why, but part of it, I think, relates to funding.
Right. Yeah.
And the uncertainty, if you develop a hospital, am I going to be funded or not? That's the problem.
It's a shame that it has to rely on that.
It is.
And there's no other sort of sources.
No.
I think that just shows you how important getting your funding correct is in whatever you're doing.
Yes.
It drives productivity, and as you can see, it's even driving efficiency through these the day hospitals.
Yeah, that's right.
So Jane, you've been Day Hospitals Australia CEO for, I think it's about 10 years now.
Just over 10, yes.
I would guess you've probably seen some of the most interesting times out of any CEO. I was just wondering, besides, I know obviously avoiding the collapse of the system is an obvious thing and goal of yours, but I'm just wondering what your goals are in your role. I think we're really lucky to have someone like you in such an important role. I think if people heard this, they'd probably be a little bit, I'd expect them to be concerned about the state of things.
Yes.
And to care about them. I mean, I care even when I hear we're not leaders. I always think of Australia as leaders. I know Danny does as well. So, I just wonder what you hope for the sector and in your role for the coming years.
Well, one of the most important is to have accurate data. And that's why this document's so important. However, we were constrained with this document because the states do not have a national term for day hospitals. Only 2 states refer to day hospitals as day hospitals. And of course, they're all hospitals because they wouldn't be funded by the insurers if they're not. But all the other states refer to them as day procedure centres. And we think that's a hangover from when they were in the hospital. And that's what they're called, in the hospital. So that's the first thing. The second thing is, and actually I've got a meeting on this in about half an hour, is the definition I mentioned to you earlier, the international definition, because what happens in some states, the minute the patient stays overnight, we lose all that data, even though they're less than 24 hours. So there's a couple of states that have 23-hour licensing. I'm not quite sure why they forgot about the 59 minutes, but there's only 2. So we have been talking to all the states, and in fact, I'm talking to Victoria shortly because it requires legislative change. So it's not going to be an easy task to change that terminology across the board. But in America, they're all ambulatory surgery centres, not different names in different states. So that's confusing for patients because patients know that they are covered by their health insurance if they're admitted to a hospital. But when something's referred to as a day procedure centre, what does that mean? So that's the first thing. So that would assist with data. The other is to have a fit-for-purpose accreditation system, because the accreditation system that we're forced to have does not reflect our model of care, which is very different even to the model of care for a same-day procedure in an overnight hospital. So we've had support from all quarters. The stumbling block has been the commission, but we had a reasonable meeting this week, and we will not give up on this because it's so important. There's 2 critical elements that are completely missing from the current standards. The first is the pre-admission assessment, which is a really detailed assessment of the patient, absolutely necessary. Things can change between the doctor's original consult and their admission. So that assessment is vital, and there's no time to do all those things when they come into hospital. So at the moment, the way the accreditation actions are worded, this all happens in the hospital. So that's one, and the other is at the end of care is the post-discharge follow-up, which is crucial as well, and will be more and more crucial as we do more advanced procedures. But then there are things like maintenance. Maintenance is hardly referred to, but day hospitals don't have bioengineers. They don't have maintenance departments. So they are totally reliant on contractors to do that work. So there needs to be an assessment of the maintenance records and even down to the calibration of the equipment they use to test the equipment in the hospital. So we feel very strongly that needs to be beefed up a lot. Same thing with IT. Most day hospitals would outsource their IT. And as you mentioned, with AI and cyber attacks, this is going to become more and more important. And again, is not addressed in the standards. They're definitely written for large, overnight, public, and to a degree private hospitals. Assessing someone for dementia and cognitive decline when they come in is not appropriate for a day hospital. That needs to be done. They may not be suitable because they won't be able to look after themselves. But that's another expectation. There are things like, although we've managed to get this changed, a national inpatient medication chart, which was totally unsuitable for pre-op medications for ophthalmology, for example. And people were getting not meds for that, but we've managed to address that because it was just ridiculous. So, and the other one was an observation chart that they insisted that even people having local anaesthetic had to have, when if you go to your dentist, you don't have all that follow-up after you've had a local in your mouth. That's no different anywhere else in your body. So it was all unnecessary work, just taking staff away from care of the patient. So yes, accreditation for us is a big project. We've been working with the largest accreditation body in the US for ambulatory surgery. So other countries have specific accreditation for these sorts of hospitals. And we've been challenged with trying to convince the Commission that, really this is necessary. I mean, only recently they brought out special standards for cosmetic facilities. So to me, that demonstrates that the model wasn't working for those facilities because they're different. So yes, we're hoping it's not too far away.
One thing out of curiosity, I was just wondering what your role entailed as the Australian representative at the General Assembly of ambulatory surgery.
Yeah, it really the main aim of the International Association of Ambulatory Surgery, IAAS for short, is to promote quality same-day surgery worldwide. So as an Australian representative, we contribute, or I and John Napoli contribute to the wealth of knowledge of what's happening in our country, but also learn from other countries. But another part of our role is to engage countries that perhaps are in their infancy in developing same-day surgery. And I've engaged with New Zealand, who are way behind with same-day surgery in standalone facilities, and South Africa. So they're now looking at joining IAAS. But to be part of the General Assembly, you need to be a national multidisciplinary body that represents the country's expertise in same-day surgery. So John was originally on the GA himself and shared it with a nurses group who who folded during the pandemic. I think they're sort of looking at reforming now. But then I was asked as the peak body CEO that I should be part of it. So my colleague, Bill Prentice, who's in the same role as I am, but in the US, of course, his organisation's massive. We have lots of discussion around that. And that, I guess that's one of the benefits, is that we're exposed to what's happening everywhere else, as well as informing the GA on what's happening in Australia. For example, at the conference in May, I presented on fit for purpose accreditation to the international audience. So it's a very important role, and certainly I think is respected by the government, that they know that Australia has a role in that forum. But yes, it is an important part of my role. But I guess the key elements of my role are to support, represent and advocate on behalf of the sector and our members. And a lot of my time is involved in advocacy. I sit on, I think it's about 8, either industry or government committees, and I've made sure that my directors on the board are on at least one, so that between the 10 of them, they're on 12 committees. So we're well represented. Now that's probably increased during the reign of Greg Hunt, who absolutely understood the sector. So before Greg, we didn't have the support of the government that we have now. And certainly that's continued with Mark Butler.
It must be good to have a finger on the pulse of what's happening everywhere around the world too, so you can implement what they're doing as well.
And they produce a journal which is mainly research, which our members have the opportunity. They're all automatically members of IAAS because of our association, so they automatically get access to that journal, which comes out quarterly, and can see all the innovative research that's happening in day hospitals, and mainly medical, across the world.
I just wanted to say thanks for today, Jane. Thank you for your time. It's a thrill for Danny and I to have someone like yourself on the podcast. It's kind of mind-blowing that we have you after someone like John Kelly, and I really hold people like yourselves in the highest regard. You're similar to him in you've got a nursing background, and I think that really defines how you hold yourself and how you manage and what you care about. So I recognize that. I think it's really evident from speaking to you today. And yeah, thank you for your time. It's really appreciated.
Pleasure.
Thank you, Jay.